staying with us for the very last webinar of our lipedema awareness web series. Thank you for staying with us all these 2 months. It has been a very exciting journey for us. Thank you for staying with us, following us, asking questions, and be involved in all our initiatives. Thank you very much. I will be very, very short today because we have a very intense program for tonight. So we will have our journey will be in Italy today. So we are very proud to introduce Dr. Michelini, and then we will spend some time together, all we three association and Lympha, Lipedema Italia and Lipedema UK, suggesting and presenting our idea, our proposal for the manifesto of lipedema. So stay with us. We have also a little surprise in the Q&A, because Dr. Karen Herbst will join us in the Q&A to answer all your questions. So stay tuned. Ask anything you need on our socials. Follow us on our Instagram and Facebook and YouTube according to the language. Or you are super expert now, so we don't need anything else. Yes. So now, Marcella, would you mind introducing our Dr. Michelini?
Yes, with joy. So I would like to talk very briefly about Dr. Sandro Michelini, that everybody knows as one of the main experts worldwide. But just a few words because we are so proud that he is with us today. Dr. Michelini is the director of the Service for Diagnostic and Rehabilitation, Vascular Rehabilitation at the Hospital San Giuseppe di Marino. He is writer from over 300 publications in scientific and science. And between them is the one about genetics, about lipedema. We found the gene, the mutation in a familiar nuclear from lipedema, not syndromic. He's teacher in courses from formation. He's speaker and responsible, scientific or responsible in several events, congress, national and international kind, about lipedema, about lymphedema. He's the coordinator of the Ministerial Commission of Health and wrote the author of the line guides for primarily lymphedema and secondary. While during his very prolific career in medical and assistential field, he recovered several roles, very prestigious. Just to say few, he's the president of the European Society for Lymphology, vice president of the Italian College for Phlebology, vice president of the Italian Society for Lymphatology. He was the past president for the International Society of Lymphology. He's a member of the executive committee of the European Society for Lymphology, and actually the president of the Italian Society for Phlebolymphology. Actually, he is the president of ITALF, Italian Lymphedema Framework, and president of the international organization LVA, Lipedema World Alliance. Would you like to say more, Valeria?
No, you've been super exhaustive, and we know that Dr. Michelini has a very long career, so I prefer just to give the word to Dr. Sandro Michelini and to listen to his super interesting presentation he made for us today. Thank you, Dr. Michelini. The stage is yours. Thank you.
Thank you.
Thank you.
It's a very pleasure for me to speak, and I thank all of you for this opportunity gave me to speak about this pathology, still today not well known. before to present the future activities of the Lipedema World Alliance, I would like speak you tell you about some consideration regarding the lipedema, the illness. Some of you will remember that a webinar was organized by Lipoedema Italia Onlus in December 2020. On that occasion, I myself, together with many qualified colleagues from various countries, first of all, our friend Karen Herbst, felt the need to distinguish from the interpretative point of view some substantial points that characterize lipedema with respect to what is stated in a document of European consensus achieved in fact by some German colleagues and endorsed by other international colleagues. These authors suggest in this draft European consensus document, for example, the modification of the term lipedema in lipalgic syndrome, the so-called renaming. Despite this term is recognized by the World Health Organization, by the assumption that lipedema, it would not be an edema classically understood as such, consisting essentially of the accumulation of tissue fluids, and that pain is one of the most disabling clinical symptoms. In reality, the term edema derives from the Greek word edema, which means swelling, not specifying what disease caused by. And about 20% of patients who suffer from lipedema, it not present this clinical symptom of pain. For these reasons, since the swelling is essentially sustained by an abnormal accumulation of fat cells in certain body regions, the definition term lipedema still appears to be congruous today and has an easier impact in recognizing the pathology. This is the website in which the German colleague Erika Mendoza proposed to the healthcare operators or to the scientific societies to create a new name for the illness, removing the term edema. But just to demonstrate the mistake of scientific thinking, I propose to you this interesting study of our Italian colleague Marina Cestari, just presented in the last European Congress of Lymphology in Assisi some weeks ago, that is publishing on the lymphology research and biology, in which she demonstrated the presence of fluid stasis inside the adipose septa of lipedema. This, however, justified the positive response to the treatments classically addressed to drainage, such as the manual lymphatic drainage, the pressotherapy, and the bandaging, for example. You can see that the two-dimensional ecography, classical two-dimensional ecography, in this kind of examination, you not are able to recognize, like in the three-dimensional execution of the exam, this lake of fluid just involved in the septa of the lipid tissue. This testify also the fluid component of the classical fluid component of the edema present in lipedema. This is publishing next weeks on the impacted review of lymphology research and biology. Very interesting, as known. Lipedema is a group of undefined disease that recognize in pathological growth of adipose tissue in certain body regions, an element that unites different clinical pictures still to be investigated still today, understood and defined from a nosological point of view. Disease, the disease was already known in ancient times, and over the centuries it has also been portrayed in works of art that have come down to us from various civilizations, such as the bas-relief discovered in the tomb of the Egyptian princess Punt in Luxor, the Etruscan sculpture, as you can see, of the Venus of Milos, and the same Three Grace of Rubens, the marvelous pictorial work transmitted us by the Flemish master, as you can see. The framework common to the different syndromic aspects is determined by a symmetrical accumulation of subcutaneous fat, chronically progressive, accompanied with orthostatic edema, which almost exclusively affects female sex. In most cases, the subjects who are affected have a normal body mass index, and despite this, many clinics still today believe that the disease is very linked to some epigenetic aspects, especially wrong diets, with consequent incorrect address of patients to bariatric surgery with further damage to them. The disease in its various aspects is relatively wide in the female population. It has an evolutionary character. A large number of doctors still today are unaware of lipedema and its symptoms. Many people with lipedema are misdiagnosed or not treated until after decades of clinical symptoms. This is a reason for important expenditure on aesthetic products and service, often useless. It is often confused to conclude these aspects with lipedema, with lymphedema, lipedema with lymphedema. The etiology to date is still not fully defined. The genetic hypothesis was already supported by the first authors who described it as a family one in an observation range that fluctuated between 16 and 64% of the subject. In 2020, our team discovered the first gene that, if mutated, is responsible for the phenotype, the alpha-ketoreductase 1, an enzyme involved in the metabolism of progesterone. We are sure that similarly to lymphedema, also for this disease, with differentiated expression and clinical components, it is determined by more than one mutated gene. Research also in this sense must proceed to help us better understand the various phenotypic manifestations with which the disease presents itself. The role of hormones is also undoubtedly important. This is demonstrated by the almost exclusive involvement of the female sex at the onset at the puberty in the majority of cases, and the accentuation of the clinical picture during pregnancy and at the time of the menopause. The same rare cases present in men occur in subjects with particular genetic syndromes or in the presence of liver cirrhosis or in the course of hormone therapy for prostate cancer. The relationship with obesity is not clear. It is certainly not systematic at all. In our experience, many subjects have a body weight even lower than normal, because those affected avoid part of the daily food intake with behaviors bordering on anorexia to avoid by taking in calories, an increase in tissue volume location of the disease. It is clear from a conspicuous literature that diets low calorie do not have the desired effects on the areas of the body affected by lipedema, as does physical exercise, to which other adipose deposits of the same organism respond. Conversely, the white increase is primarily poured into the affected areas. This is a very interesting pedigree in which is clear the possibility that man, as you can see, ever health carrier, can transmit the pathology to the following generation, ever in female sex. And this is another interesting pedigree in which there are many female subjects of the same family who present the same clinical picture in a 4th generation, as you can see. Very interesting. The familiarity is the family problem is present in all these patients, but from the family of mother and from possible family of father. This is the article that describes the first mutated gene, as just said, the alpha-keto reductase C1, responsible for non-syndromic lipedema, in the sense of not associated with other particular morbid conditions in these subjects. In none of these 3 consanguineous, for example, patients, the pain symptom was present. This is very interesting. The chronic adipose tissue inflammations is the typical histopathological aspect that we found in lipedema. This is characterized at the microscope level with infiltrates of inflammatory macrophages, which, through the release of inflammatory cytokines, will stimulate the differentiation of new adipocytes, starting from mesenchymal stem cells, from which hypertrophy and hyperplasia of the adipocytes is. The increase in size and number of fat cells would lead to a reduction in local vascularization, a reduction in venous return, and the lymphatic drainage with the consequent hypoxia and the onset of inflammation, which in turn with a vicious cycle. Would again stimulate further adipocyte production. At the same time, the same macrophages, through the release of the vascular endothelial growth factor, would promote the formation of new vessels that recent histological studies have shown to be dilated with alteration of the vessel wall. All these in the absence of the consensual lymphangiogenesis with stagnation of lymph and contribution to the formation of edema. The results of chronic inflammation of the adipose tissue is manifested by the appearance of tissue fibrosis and the compartmentalization of hypertrophic and excess adipocytes in macronodules. In spite of what has just been demonstrated, the World Health Organization has placed the lipedema among the non-inflammatory disease of the adipose tissue, as you can see. This is another field to approach by the Lipoedema World Alliance. These aspects are very important for the institutional meaning of the same. The common clinical aspects of the disease are represented by familiarity, onset at puberty, the accentuation of the clinical picture with pregnancy and with gynecological surgery. The distribution of fat occurs essentially in the buttocks, and in this sense is distinguish lipedema from the lymphedema. Never interested the buttocks in lymphedema, ever in lipedema. Thighs and legs for the lower limbs, in the arm for the upper limbs. There is a clear demarcation between diseased tissue and healthy tissue at the ankle and the wrist, with saving of the feet and hands. The development of the diseased tissue is simultaneous, bilateral, symmetrical. There is no response to normal low-calorie diets. Impressive edema is typical of the advanced stages of the disease. There is a poor response to exercise and diuretics. Pain is present in over 80% of the subjects and is accentuated with acupressure. Spontaneous hematomas in the affected limbs are present. There are 4 clinical stages, well known, In relation to the localization of the normal adipose tissue, 5 types have been conventionally described, which are observed, you can observe in the slide. Localization only to the buttocks, localization type 1, localization that extends to the thighs type 2, which also affects the legs type 3, which affects the upper limbs type 4, and only legs type 5. But this is the evolution of the fourth stage. The third stage severe is the fourth stage. But in reality, in daily clinical practice, it is possible to observe as many as 9 different types of localization that can vary affect only the localization of the lower limbs in the various locations, or at the same time both the lower and the upper limbs, as just said. Severe localized pain is reported when the medial below the knee joint area at the fibula head level is pinched deeply. It is a pathognomonic sign, the Simarro sign. The Simarro spoke some weeks ago to you about his experience. Is a pathognomonic sign of lipedema, which is present from the early stages of lipedema. It is present even when lipedema does not affect the lower half of the legs. It could be the expression of the underlying panniculitis, these aspects, or represent a suffering of the ligament structure of the medial knee, in particular pes anserinus insertion. This anatomical region is composed of the 3 tendons, the sartorius tendons, the gracilis tendon, and the semitendinous tendon, and it is affected by weight overload and predisposing anatomical factors such as valgus knee and recurvatum knee, very frequent in the woman. Patients with mechanical overload often experience these postural alterations with repercussion of the tendon structure of the lower limbs. To this data, as well as we will see later, joint hypermobility is often added as a condition associated to lipedema, and that contributes to knee instability and the consequent ligament and tendon structural alteration. Medial knee ultrasounds, you can see, in these cases, it is useful for discriminating pes anserinus bursitis, like in these cases, as circumscribed anechoid fluid collection, from the pes anserinus tendinopathy that shows increase in thickness and the loss of fibrillar partner, as you can see. Regarding the pain, this is present in over the 8% of subjects, as just said, generally more intense in afternoon and evening, measured by means than a numerical rating scale. It seems to be correlated with the value, also correlated, not only, but also correlated with the values of pregnenolone sulfate, a very recent acquisition, an endogenous neurotransmitter, neuroendocrine hormone, inhibitor of the receptor of pain transmission channels GABA-A. In our experience, the higher pregnenolone value corresponds to the lower pain sensation. On the contrary, lower pregnenolone, very frequent in these patients, concentration correspond to greater presence and intensity of pain. There are other comorbidities associated to lipedema in our experience, but reported also in several recent clinical studies. We have found cases of insulin resistance, Hashimoto thyroiditis, autoimmune thyroiditis, low levels of vitamin D, articular inflammation, hypermobility, endometriosis, alteration in the menstrual cycle with different percentage of recurrence. The possible association between lipedema and daughter's hormonal and metabolic pathologies remains to be investigated more carefully. Few studies demonstrate a weak correlation between lipedema and endometriosis, polycystic ovary syndrome, and pathologies like diabetes, hypertension, and dyslipidemia. These last generally are present in obese patients as part of metabolic syndrome. In lipedema, there seems to be little association, so this aspect is still subject of study still today. Low levels of vitamin D have been detected in patients affected by lipedema. It depends from the fact that it is a fat-soluble vitamin, so it can distribute in several compartments of body, such as adipose tissue. This is increased in case of lipedema, and it carry out to a sequestration of vitamin D that it seems lower because reflects a volumetric dilution effect. This data has been demonstrated in obese patients that often have also vitamin D deficiency. In patients with lipedema, low vitamin D levels are very common and they have several negative effects that worsen the pathology. In addition to an increase of adipogenesis, we have an increase of inflammation that contributes to worsen pain and an increase of insulin resistance. Important effect of low levels of vitamin D is the muscle weakness associated with muscle pain. As we have just seen, patients with lipedema suffer because of their physical and functional condition of mood disorders that low levels of vitamin D contribute to worsen. So, during the overall evaluation of patients, the dosage of some laboratory parameters becomes fundamental to investigate the possible associated comorbidities, starting with the blood sugar test that is useful to detect insulin resistance, condition present in very more patients, to thyroid function, lipid profile, hormonal test, and the dosage of vitamin D. This it could represent one of the therapeutic options in lipedema, since several studies have demonstrated that vitamin D inhibits formation of new fat cells, regulates fat cell activity, and reduces visceral fat in both overweight and obese adults. Hypermobility and other aspects is a condition reported in association with lipedema. That they range from 10 and according to some authors, 50% of women with lipedema had a positive Bayton score over 5 like score. Joint hypermobility could be associated to Ehlers-Danlos syndrome hypermobility. Pain is a common component of Ehlers-Danlos syndrome hypermobility, and females are functionally affected to a greater extent than males, and therefore this association should be further investigated. In the overall examination of lipedema patients, Bayton score could be useful to assess the presence of joint hypermobility when the score is greater than 5. As we have just seen, hypermobility confers risk for additional joint damage and alteration of gait in women with lipedema. There are also other implications of connective tissue alteration that we found in lipedema patients. Skin changes, including thin skin and the tattoos that leak into the skin, can be found in women who are hypermobile. Hypermobility may change the structure of the lipedema tissue, affecting how much fluid fat can accommodate. Leakage of fluid from vessels, dilatation of vessels, and the dysfunction of capillaries. Women with lipedema also have a higher aortic distensibility and strain, reliable characteristics of arterial elasticity, also suggestive of connective tissue changes consistent with the hypermobility and the possible risk for cardiovascular mortality. To obtain the best results, it is necessary to involve a multidisciplinary team, each for their own specific skills, as you can see in this very significant slide. What weapons do we have at our disposal? There are two types of therapeutic approaches for this pathology. The first is conservative. The second is surgical. But as I mentioned earlier, there are no guidelines in this moment that firmly indicated when and what to choose. There are still few clinical trials conducted on the management of this disease, sometimes with discordant results. Aspects that must certainly be taken into consideration with regard to the type of therapeutic choice to be made, such as the degree of pain of the patient's disability, the presence of comorbidities, any compliance with conservative treatment, economic and non-financial resources. Patients will must be taken in consideration at the same time. The patient in all these aspects. Pain, disability, comorbidity, compliance of patients, very hard aspects, complication, economic results, and patient's will. Fundamental in the is the wearing the flat needed garment in all cases. This is an aspect very important to obtain by the institution for these patients. Another goal. Last year, the USA guidelines on lipedema were published, a work coordinated by Professor Herbst, with whom we collaborated starting from at least 3 years ago. The document in particular underlines above all the hereditary and the genetic nature of the disease, confirms that traditional low calories diets, physical exercise, and bariatric surgery do not solve the clinical problem, confirm the prescription of diuretics for therapy, and the positive use of the metformin, above all in subjects with insulin resistance, confirm the need of vitamin D, and the importance of the combined physical treatment both in the containment of the disease and in the regression of the main symptoms, first of all, the pain. The team of health workers must be culturally and practically well prepared. The document concluded that there are two surgical techniques very effective on the lipedema among the many currently used to maintain the clinical results along the time: the WAL, water-assisted liposuction, and the PAL, power-assisted liposuction. Starting from all these considerations, and we arrive to the goal of today, to the fight of today, we decided to create, with more other colleagues, to create the Lipedema World Alliance, or LWA. LWA proposed to create an environment where healthcare professionals from different countries and patients associations collaboratively explore many unanswered questions around lipedema, and to promote scientific dialogue in order to accomplish the goal of improving the understanding and care of people living with lipedema. This is very important mission of this in theory, and will be also in a practical way. According to the World Health Organization, collaborative practice happens when multiple health workers from different professional backgrounds work together with patients, families, carers, and communities to deliver the highest quality of care across multiple settings. Lipedema has long been a Cinderella condition, ignored and neglected. Recent interest, research, and publicity has often been driven by patients' desperation and passion to find answers and reputable healthcare providers. At this time, it is a risk to reach a conclusion that prevent future research into important areas that affect how people with lipedema receive treatment. This is an argument very important and hard to approach. Lipedema requires continuous exploration, and we want to do this together. Working together, we can make a change of the mentality on this way. Collaboration and dialogue. This is very important for patients and also for sanitary operator, as there is still so much to learn about the pathology of lipedema and the best ways in which it can be managed and treated. Lipedema World Association believes passionately that the best way to discover the optimal approaches is to do so in a collaborative spirit, patients, advocates, and the professionals coming together. We feel that this collaborative effort will promote the following goals: a dialogue of priorities and the concerns amongst patients, clinicians, and the researchers. The research is very gap important in this moment. Identification and prioritization of areas where research in lipedema should continue and should not be limited. Development of on based educational materials supported by science, and access to diverse research participants from across the globe. This is our intention. In order to facilitate these goals, and as a respected member of the lipedema community, we would like to invite you to join to the Lipoedema World Alliance. Membership is open to healthcare professionals and researchers, registered patients, and scientific association. And this is the last new that I give you. Starting from the 1st September of this year, you can subscribe to the association by writing to this email indicated in this slide. I thank you, all of you, for the attention, and we can discuss about these aspects. I think very important for all of us.
Thank you very much, Dr. Michelini. Such an amazing presentation. Thank you. So we are moving to the second part of the webinar. So can you please share the screen of our slides to present the manifesto? So, Kate, it's your turn, I believe.
It is. Thank you, Valeria. So we are super excited to hear what Dr. Michelini's talked about. But before we hand over for more questions to Dr. Michelini again and Dr. Herbst, we just wanted to talk a little bit about the next steps in our collaboration. We think it's really important, as Dr. Michelini was saying, that we focus on what it is we agree on about lipedema, what we think the questions are in lipedema, and that we really believe that these questions are bigger than any one country and they go across national borders. So we really want to call on all our sister associations to join the collaboration that the three of us have started, and to go further and to go deeper in doing that. Because we believe really strongly that people who live with lipedema have a voice that needs to be heard, needs to be included, and needs to be celebrated with that support for advocacy and in determining what the research priorities are. So we want to tackle all the unknowns together in partnership with the researchers, scientists, and great experts such as we have with us tonight. Because as Shari, our chair of Lipoedema UK, is always fond of saying, #together we can beat lipedema. And I think we believe that so strongly in the core of ourselves. So if we move to the, I can move slides. Wow.
Wow. Can we ask to our supporters for technology that to insert Sherry? We can just take a moment aside, Dr. Michelini, for a moment. And okay, we see Sherry now.
Hi, I'm here.
Okay,
thank you, Sherry. So as we were saying, delivering these webinars together has been a great example for us about collaborating outside our own organisations. It's enabled us to do something really exciting. As Dr. Michelini said, building on the first webinar we did together a couple of years ago, where we've been able to use translators and to interpret into different languages the work of a variety of really great doctors and experts, and to bring in expertise that otherwise in our own associations and countries we wouldn't necessarily all have known about or have the access to. So we think that working together is really a great way of bringing in these sorts of different experts and then providing information in the languages that we're really comfortable with. So it's been amazing. And what we want to do tonight is tell you a little bit more about why we think we need a manifesto in particular, what it's going to do. And we really want to encourage other associations to join our collaboration, as together we're stronger. So what I'd like to do now is I'd like to bring in the chairs of our three associations just to tell the listeners in other countries a little bit about who we are and what we do. So Shari, do you want to start by telling people a little bit about Lipoedema UK before we then hear from
delighted. Yeah.
Thank you.
Well, good evening, everybody. I am so excited this evening's event because I've been involved with Lipoedema UK for 10 years now, and it has been a long 10 years. And all along, we've known that collaboration with the top people in the fields and making lipedema an exciting subject is the way to make progress. I'm always so impressed when somebody like Dr. Michelini shows us all the research he's been doing in the background, because sitting where we all are in these isolated bubbles, and lipedema people do feel very isolated. We aren't always on top of everything, and we need that reassurance that we have top-notch people and skills fighting for a condition which, as we've said already, is the Cinderella condition. We all want to go to the ball. We're really ready to go to the ball and have fun. So Lipoedema UK has been working with surgeons, with experts at St George's Hospital, with the top medical people in the UK for the whole of the 10 years. We're very lucky that we had the backing of Professor Peter Mortimer and Dr. Christiana Gordon right at the beginning. Lipoedema UK have been involved in the genetic research and recruiting people. We're always very, very keen to recruit people for studies, to participate in research. And we've done our own surveys, which we feel have contributed to knowledge about the patient's perspective. So that's Lipoedema UK as it is today, and it's just onwards and upwards, I hope. Thank you very much.
Thank you, Shari. Valeria, do you want to take us onwards and upwards by telling people a little bit about Leo?
Yes, Lipedema Italia was born in 2018, and since then it's a non-profit organization supporting people with lipedema in Italy, and also all the people who take care of them, so caregivers, family, healthcare professionals, and so on. We are all lipedema sufferers or caregivers who volunteer to offer some support and information to the ones suffering from our disease. So our main mission is to raise awareness in lipedema, to advocate and support people with lipedema, provide a very safe and supportive and educational resource through, for example, our website, our social media, and through organizing many informative events about the disease. And so we are still fighting to have lipedema treatments covered by the Italian health system. So we want every lipedema patient to be treated and taken good care of. So we try to provide verified and scientific information and resources for ongoing management of lipedema. And we are very concerned in gathering lipedema clinicians and patients together. And this now also gathering association, gathering all the people that could help, could build together a brighter future for lipedema sufferers.
So perfect, Valeria. Manuela, can we hand over to you to tell us a little about Andlinfa and then to take us on in the presentation?
Okay. Thank you very much for all your presentations. Here in Portugal, we are in the very beginning of everything, and lipedema is really almost not known. We are an association not only for lipedema but also for lymphedema, primary and secondary, and also for rare disease in vascular area. So I have no lipedema, I have primary lymphedema, but I want to fight, and I want to fight with others that have lipedema and are in our association for the good answers for a patient in Portugal. Of course, Dr. Michelin spoke about ECD11 in a few minutes ago. Here we have also the ECD11, but we are still in ECD9, for instance, in the securities. So it is a little bit complicated, but we want to fight and we are going to win. That's why we are stronger together. And to be with you, Valeria and Sherry and Kate and Marcella during this period, it was really very a pleasure, because I learned so much with you, and I have to thank you in public, because you know that I'm thankful, but I have to say it in public because I'm really thankful. And Portugal is thankful for you too, because through you, a lot of Portuguese people could have access to a lot of information. That's why to be together means so much for all of us. So you help Portuguese people, not only me, because I'm nothing, but you help a lot of Portuguese people that suffer with lipedema with the good information, and that's the best for us. I'm sorry, I don't want to be emotive, but that's the truth, and I have to recognize that in public. Thank you to all of you. Thank you very much.
I think our hearts are so full. Before we all start crying, it's probably best that you start writing the presentation with the little buttons at the bottom to take us forward while we all.
Okay.
Bad lady, you made us all cry.
No. That's the truth. That's the truth. Thank you very much.
It is. So yeah, you should be able to just use the little forward arrow.
I know.
I would like to say, Manuela, we've learned a lot from you too. You've been the bedrock of this collaboration, and you give a lot to everybody. So thank you from all of us.
That's my pleasure. That's really my pleasure. So thank you. So just to let you know about Patient Advocate for Lipedema in the World, which is a page in Facebook. So we start, this is, as I told you, I'm a lipedema patient, And I learned also a lot of with my colleagues in Europe about how to be an advocate in this area. So sometimes it's not necessary to get a new will. It's just to use the right will and give the credits who create it. So the lymphedema advocates create a page in Facebook, and we bring all our words and our fights on that page. So we replicate that in lipedema. I'm sorry. Uh, we replicate that for lipedema, and we are doing all the same here. So sorry, next. So that's the reason we create. It's to find out that we are not alone. We have the same goal, and so everybody in our country, in our countries in the world, can come here and say what they are fighting for. We are not only the faces. You are fighting for the good answers and the good reasons, and we are not the only one working as volunteers. And we are not only the life stories and talking about everything today. So as you can see, we can have different people and different associations from the same country. The importance here is only the goal. And here in UK, you have different faces. A lot of them will come, I'm sure, and also from Portugal as well. This is my dear colleagues from Portugal that are working and fighting for lipedema in Portugal. And sometimes our language, like Portuguese, can cross the world and go to Brazil and come together with us. So the language is not also the problem, and also the sex. The important is the goal, as you can see. If you are fighting for, that's the most important thing. So men can also be the part, because they are very good partners, and can also be the part of the if they are associated. Here you have also different people, like for instance from Sweden. She is not a lipedema patient as well, but she is also in her association, so they are also fighting for lipedema. So the goal is the most important thing. Advocacy has not the same goal, not sex, as I told you before. So please, if you want to join us, just do it. We are waiting for you. You want to be with us. It's not necessary to be from the World Lipedema Association. It's just we have the same goal, and it's the most important thing. And of course, oh sorry, where is the slide? I don't know your faces, but I feel that you can be with us. I want that you can be with us, and I know that if you are with us, we are also stronger than we are now. So please come to us. And how can you be with us? That's quite simple. So it's just to have a photo, to give your name and country, and the name of your association, and the message in English and in your mother language. So 2 slides if you don't speak English. Some people are privileged on only 1 slide because they speak English, but others, please, it's in English and mother language. So if you are working in an association and you are an advocate, you can be on this page. You can also be with us, and send also your message in this with I don't know, I can't remember how many, 138 characters, and send it to us. We are waiting for you. I'm sorry, but together we are really stronger.
We are.
Okay, I will pass your word, Sherry.
Thank you, Manuela. And you're right, it's an amazingly kind of inspiring kind of project and activity, because it lets us all express ourselves in a really interesting way. So please, anybody who's interested, do watch back, grab that slide and get in touch. What we want to do now is take you through this manifesto that we referred to explain a bit about why we want to have one, what it will do, and what we suggest is in it. So we have 9 points that we think are something well, I guess our 9 things that we think are important, are something that the diversity of organizations working with lipedema across the world could agree on, and that we can all unite behind to use as a really clear and powerful message with politicians, with healthcare, whether it's insurance providers or national system providers, and that we can say to everybody, these are our rallying calls. So what we're now going to do is I'm going to hand over to my colleagues to start taking you through each one of our 9 points to tell you why it's important and to show you what it says. So Marcella, to you.
Oh, thank you. I will start to read the statements, the first statements in our manifesto. The first statement is that we can go to the next slide. Thank you. The first statement sounds: lipedema is a global health problem that affects people worldwide, mainly but not exclusively women. The literature has shown both scarce and conflicting data regarding the prevalence of lipedema. Statement 2. Lipedema is a chronic and potentially progressive disease of the loose connective tissue, often painful. It is a fat disorder that can cause severe deformity and disability, psychological and economic burdens. Statement 3. Most health professionals are not fully aware of the disease or its signs and symptoms, causing people with lipedema to suffer for many years before they obtain a diagnosis and begin the treatment. Lipedema can be mistaken for obesity, for lymphedema, or not pathological embarrassing cosmetic conditions like cellulite. Statement 4. There remains a low public awareness about the health impact and variation of different fat disorders, which has a significant impact on the lives of people with lipedema and the stigma they face. Access to appropriate and timely treatment is often diminished, and the patients frequently find themselves blamed for their condition, including self-blame. Statement 5. There is no cure for lipedema yet. However, it can be treated to reduce symptoms, maintain mobility, and improve quality of life while slowing disease progressions. People with lipedema need access to high-quality, multidisciplinary, specialized centers and experienced health professionals in order to receive appropriate treatment, covering physical, psychological, and social care. Valeria, would you like to go over?
About the statement 6, there is a deep unmet worldwide need to educate and support individuals affected by lipedema, including family members and caregivers, on this medical condition and the most effective self-management to improve their quality of life. Statement 7, medical research efforts to find a cure for lipedema and to optimize treatments are lacking sufficient findings in comparison with diseases of similar magnitude and severity. Statement 8, worldwide research should focus on patient quality of life, nutritional guidance, management of comorbidities, techniques to reduce inflammation and fibrosis, earlier diagnosis to allow for intervention and education, psychological support, as well as pre- and post-surgical protocols to improve care and medium to longer term outcomes. And then the statement 9, patient empowerment, defined by the World Health Organization as a process in which people gain greater control over decisions and action affecting their health, is a key theme within global health and social care strategies. Lipedema patients associations play a crucial role, partnering with professionals in evidence-based medicine, shifting the focus from the disease itself to people living with lipedema. We believe patients should be involved in determining research priorities and treatment options. So there is no evidence-based medicine without the patients, without patients' values and expectations. We are necessary, an important part to define EBM. So we patient association have actually a very specific role in this, because in a structured organization as we have, we can collect the voice of patients in the most scientific way we could, using, for example, PROMS and PRAMS questionnaires to scientifically collect the patient voices. And also we have, I'm sorry, the slide is in Italian, because we in Italy have a very great research about the role of patients' engagement in we could use, for example, the PHE model, which is a patient health engagement model. This is a psychological model to activate patients' motivation and awareness from the moment of blackout to an eudaimonic moment about awareness of the disease, to improve the medical adherence. So we are super important in this, and we can't be taken outside those decisions, because evidence-based medicine couldn't be done without patients. Okay.
Thank you, Valeria. So we want to also encourage everyone to focus not only on the whole month of June, but on calling the 11th of June World Lipedema Day. We can have a bit of an English background for this, so people who are British will understand the symbology of the bingo game and bingo calling, where 11 is referred to as legs 11 because the two numbers 1 and 1 look like a pair of legs. So that's actually some of the history behind why in the early days of lipedema in English-speaking countries, we started out focusing on the 11th of June. So we want to really encourage that day because we feel that it is a very important focus, because it gives us something that we can do a lot around with kind of graphics and really calling out a day to focus on some of the attention we want from others, as well as all the other education that we have and we want to promote. June is our month where we try and focus on a number of things about raising awareness, giving information that helps everybody to live well with lipedema, to advocate for what we want for services, and to help address some of the misunderstandings, because there's still a lot we don't know, but there's also a lot where people maybe as professionals who know less about lipedema can think they know what to tell patients to do. So we really want to focus on helping everybody with that. So we conclude our manifesto by calling for the 11th to be recognised as a particular day in our awareness month, and that all the patient associations that we invite to join us in signing up to our manifesto call for particular attentions around that day, and that we also ask for attention from politicians, policymakers, professionals, researchers, and everyone to understanding what the needs are of people who live with or risk of lipedema. We think it's really important, as do our friends in the Lipedema Foundation, to focus on early diagnosis and treatment, as well as treatment of people who've lived with lipedema for a long time. So to do this, we need increased funding for research, for education for professionals who are providing care to people with lipedema, and getting improved access to that care. So that's really been a piece about what our manifesto is. And now I think we'd just like to sum up a little bit before we open the floor to our doctors for Q&As. So Shari, I think it's over to you.
Yes, I would just like to officially thank everybody who's been involved in this initiative. It's taken an enormous amount of manpower and time and effort. And the one person I think deserves outstanding thanks is Valeria, up there in the top right-hand corner. Valeria, you have been the instigator and the inspiration behind so much we've done. So a huge thank you to us. We'd also like to, we're a little team, but we've cracked on and got there. And Dr. Michelini, your support has been essential to help us get to this stage. So thank you very much. Dr. Herbst, you are so well known, so inspirational. The whole of the time I've been in lipedema, you've been there as an inspiration to everybody. So thank you. With you two involved, we know we'll just go from strength to strength. So we've also had generous sponsorship from various organizations. We say thank you so much, because we know these webinars will go on and on. They have all been recorded and they will be there for new people in all countries to view and appreciate and learn from. Because what amazes me is every time we have a webinar, I discover something new that I didn't know about, or it's presented in a new way that my brain gets it a better time than the before. And I do think, Dr. Michelini, your slides were wonderfully clear and informative. So I really thank you for that presentation tonight. So on behalf of all patients worldwide, I would like to just say, together, I really believe we will beat lipedema. Thank you so much. And over to the Q&A session with Dr. Herbst and Dr. Michelini.
Okay, do we have questions? I just want to name our donors, because Human Med, Uso Italia, Solidea, CZ Medicali, and Medi UK were the people who made all of this possible. So all these people together with us, with healthcare professionals and patients, want the best for lipedema patients. And so I totally agree with you, Sherry, that only together we are strong. And so in this moment, we are putting all our voices together, and this is amazing. So we have some question, Kate, right?
We do. So thank you so much, everybody, and we'd like to really thank our kind of presenters for tonight, because our hearts are full. You won't be surprised to learn that the content of your presentation, Dr. Michelini, has excited people. They'd like to ask you to talk a little bit more about vitamin D3 deficiency, and there are a couple of questions on it, which are: do you recommend that people focus on taking a particular amount of vitamin D3 as a supplement, or do you recommend that they attempt to achieve a particular level in their blood? So could you talk a little bit for patients about what to aim for and what your recommendations are in general on supplementing vitamin D?
In my experience, but I think, yes. In my experience, but I think is the experience also of Karen, il more patients followed during the years have not never performed vitamin dosage. In our experience, at least in Italy, have the opportunity to observe patients coming from all the regions of the Italy. And I see that the concentration, the blood concentration of vitamin D is very, very low in the majority of cases. And this is an important aspect because have some consequences under the clinical point of view. The muscular weakness, the muscular pain, also the possible fatigue of the of patients. But this is well explained also right by Karen and other colleagues. Vitamin D is a vitamin soluble and is well known that in the obesity, but also in the patient with lipedema, there is a come si dice sequestro,
Kidnapping.
sequestration. There is a sequestration of this vitamin by the lipedema tissue, not only the lipedema tissue, and the integration with natural integration of with the drugs very, very suggested.
I think it's clear. Thank you for your answer, Dr. Michelini. I have a question for maybe for Dr. Herbst. Thank you again for joining us in the Q&A. It was a super big surprise. Thanks. And we have a question from our Italian Facebook group, because a lot of patients, especially young patients at first stage, they always say they do not tolerate compression garments because they sometimes feel it worsens the pain rather than relieving it. So can you please explain this phenomenon to these young ladies who have tried every type of compression and didn't find the ones fitting perfectly?
I wish I had the exact answer, but I can say that especially in women with stage 1 lipedema, they have less lipedema tissue than stage 2 and stage 3. And the question is, why is it there? And the answer to that is inflammation. And inflammation can cause local pain. And if your fluid that's associated with inflammation, because whenever you have inflammation, you have swelling or edema. If the fluid is sitting within the tissue and not moving, just squeezing it from the outside is not helpful. It in essence squishes those poor little nerves who are already in an inflammatory soup. And I think especially in women with stage 1 lipedema, and this is just me talking off the top of my head, I don't know, this is not, a really valid answer, but I do think that the immune system is overexcited, especially early on in lipedema, or maybe especially in stage 1. So by pressing on it, you're aggravating, you're poking the bear. So it would make sense not to wear the compression until you get some manual therapy, or you work with a provider to kind of loosen things up or decrease the inflammation you have. That should then allow you to wear the compression garments. So I think an investigation, do you have inflammation? And where is it? What is it? What can you do to reduce it? And inflammation can come from anything like allergies, mast cell activation disease, having low vitamin D, not taking enough vitamin C, not getting enough exercise, eating the wrong foods. I mean, on and on and on.
Super clear. Thank you for this answer.
Remember you, Karen, also my experience of the last year regarding the hormone pregnenolone, the pregnenolone.
Yes.
In more patients, I discover value under the minimum of the range. The integration, I begin again with the integration of the hormone by assumption, and there is in the majority of patients an increase of the quality of life.
Dr.
Pain and the increase of harmonic development of the better state.
Do you think that that could potentially be because of an increase in cortisol?
Yes, we are studying. Yes.
And do you think, have you measured levels of cortisol after pregnenolone? I guess my only concern would be that if they go too high, then we have to worry about, you know, more leaky blood vessels and more leaky lymphatic vessels.
Yes.
Also the glycidic metabolism, the blood pressure, but with a very low dosage, 50 milligrams is very for each day is very for 3 months, eventually repeatable. You know, there is an amelioration, global amelioration of factor.
So do you think it
Sure,
reduces
linked to
lipedema?
the cortisonic pain. Sure.
Do you think it reduces lipedema, Dr. Michelini, the pregnenolone?
Good question.
No. Is
No?
for the symptoms. Some
Okay.
above
Okay.
all the pain and the fatigue.
Okay.
I have a question from Italy. So, given the motor deficits or mobility problems of lipedema patients, so altered gait pattern, muscle activation, why is not the motor rehabilitation is not often offered to patients with lipedema, despite people with lipedema are offered liposuction, massage, and a lot of. But what do you think about the rehabilitation with motor rehabilitation?
A question for me.
It's whatever you want.
Absolutely is useful. My personally, I suggest very often to these patients, independently of the body mass index of the is very important because more women often knee that position added to the over weight buttock and tight. This contributed to the instability of the knee and above all of the pain for the inflammation of the pes cancerinus, as just said. We perform in all patients during the clinical examination photography of the pes cancerinus tendons, just to individuate the possible hypoechogenic aspects that testify inflammation of the an increase of the intensity of signal that this is very important. It's very easy to perform. Very.
Thank you, doctor.
But it's important. And an aspect to discriminate during the examination.
Okay.
I can just add my point of view. Whenever I refer to physical therapy, I ask for a home exercise program. So, and usually they do some exercises in physical therapy while they're there because you're right. It is so important to work the muscles for women who have lipedema because muscle function is decreased from the work that comes out of the Netherlands. And when you pump your muscles, especially in your calves, you're moving lymph fluid, so you have to. But I think it has to be in combination. If you just do mobility, but your muscle is in a fibrotic cage, like Dr. Michelini just said, then it's not going to work. So you need that physical therapy, I think, to really loosen up that fibrotic cage for the muscle. Then you got to let the muscle work. And what I've noticed is a lot of women after liposuction say that their muscles in their calves were engaging for the first time in a long time. So, and I'm not saying that liposuction is the only way to get rid of that fibrotic cage around the muscle, but something has to be done to loosen it up. And I think women need to learn how to do that themselves at home, but sometimes they need professional help to teach them how to do that.
Okay.
Thank you, Dr.
I
Herbst.
agree totally.
We have another question from a patient who's asking, how easy is it to say where in a person's body they do and don't have lipedema? So whether they have it in their arms or just their legs, for example, because I think people often struggle to understand how to know the difference between regular fat and lipedema in themselves. And it really then links the question to how important is it to give someone not only perhaps a location in the body or type of lipedema, but also a stage? Is staging important? So could you perhaps talk to both of those points? I guess, Karen, that's probably a great one to start with you. It's
yeah, sure. So I think the stages and the types are not as well defined as we would like them to be. They really do need to be updated and changed. So is it important to give a stage and type? In order to communicate with each other about what we think we're seeing, yes, it is important. Is it an absolute and this is what you have for the rest of your life? No. Again, I do think it needs to be updated. In terms of being able to tell where lipedema tissue is on the body, we're still working on that. You know, there's a lot of people working on that. But I will tell you that, you know, things are starting to change and get better. For example, in the standard of care for lipedema in the US paper, we stated that lipedema affects the abdomen. And we kind of went out on the skinny branches saying that because there's some disagreement. There's people in Europe, for example, who say, no, it's not on the abdomen. So there's some recent data out of Austria showing that there is a specific gene expressed, I think it's zinc finger 423. And zinc finger 423 takes the parasites that, not the bug parasites, but the pericytes and endothelial cells and changes them into adipocytes. So, and this particular gene was found, and yes, you know that, Dr. Michelini, very well. And this particular gene.
We in this moment we are conducting research with the anatomy of the University of Ancona, and the first 6 samples of pure lipedema, body index between 20 and 25. Not comorbidities, not all other interesting clinical aspects. I will send you a video with the resume of these aspects. We observed a migration of endothelial cells to the periphery of the wall of the vessel, and an extraflexion of these cells from endothelials of the wall of the vessel in the interstitial space. This testifies the possible origin of the adipocyte from the endothelial cell. It's a very revolutionary to consider, because still today we speak of the stem cells derivation.
Yes.
We are about
We
to share
improve
those
our
results
studies.
with
We
the
will
Italian
improve.
community,
We
doctor.
collected today 20 samples, and we are studying the other 14 samples. And another important aspects, the volume of these cells, they double respect to the adipocytes of the health tissue. A very important increase of calcium ions inside the cells. Calcium is an inhibitor of the gli enzimi litici dei lipidi.
Enzymes.
Mannaggia, non mi viene.
Don't worry, doctor.
The enzyme that provoke the polymerization of the lipids intracellular.
Okay.
The calcium is
Interesting.
an inhibitor of this enzyme. It can explain the accumulation of the lipids inside the plasma.
Wow.
And the increase of volume. There are more aspects to deep. Very
Yeah, there's
also for the therapeutic approach also.
there's so much really good research going on. Just to,
for the possible therapeutical future approach.
nice. Yeah, we need therapies. We need therapies for lipedema. You're absolutely right. That's the goal, right? It's not just, hey, this is really cool stuff, but back to the question. So the zinc finger 423 was shown to be elevated in the legs of women with lipedema compared to controls, but it was also elevated in the abdomen. So we do think that we're starting to find markers of lipedema tissue. It's just not clinically available yet, but it's coming. And so right now we can't say if, and just to give a little history of lymphedema, right? So in lymphedema, if you have lymphedema of your arm, it's an patchy distribution. Your whole arm is not the same, and it all has the same amount of fluid. There are patches of fluid, there are patches of fibrosis. And I think because lipedema is this little sister of lymphedema, I think it's probably the same way. So it's probably patchy. So when you have bariatric surgery, or you go on the keto diet or the Mediterranean diet and you lose weight, you can still lose weight from your legs or arms or in your belly, but what's left behind is the unhealthy tissue, the very fibrotic, painful lipedema tissue.
Thank you, Dr. Herbst. We're going to try and squeeze in two more questions. So I will ask you both to try and be brief on this one. We've been asked in YouTube about COVID infection and COVID vaccination. Have you noticed anything? I can't remember if you've written anything about that, Dr. Herbst. Have you noticed anything in terms of the impact of either vaccination or infection with COVID on lipedema?
I have not. There are anecdotal reports from my patients of how sick they got after the vaccine or not. And I just heard from a woman who took Paxlovid and her lipedema got better. So that's all I have. I haven't written anything, nor have I seen anything.
Almost sounds like it's good to get COVID if you can get Paxlovid and get a little bit of temporary lipedema relief.
Yeah. But that's one person.
COVID. Don't take my advice, guys.
Not fun.
This is also my experience. No differences, clinical differences. but in some cases, we are in Italy, we observe with a certain frequency the possible mutation of an enzyme, the methylene tetrahydrofolate reductase. Methylene tetrahydrofolate reductase. A gene that, if mutated, can improve the concentration of homocysteine. The high level of homocysteine can vascular thrombosis. Is of the above all venous complication. Venous is superficial, not deep. But in Italy, one subject every 5 presented this mutation. It's not easy perform the association with lipedema.
Thank you, Dr. Michelini. I think as we're moving into starting to think about autumn, despite our beautiful warm weather, where we know many countries will be offering people who have high BMIs or who are a certain age their COVID booster vaccinations, I think it's been really helpful for our audience to know that they shouldn't be overly concerned about taking up that invitation overall. So that's really great. And if I could just ask you both one last sneaky question. Our last sneaky question is, what our YouTube audience have asked, what are your 3 top tips for people for their own self-care? They've been watching all our webinars, listening to all the research, everything you're saying. Their brains are like, wow, so much to think about. What do you recommend they really focus on? What do they start doing tomorrow? Should we start with you, Dr. Herbst?
Oh, yeah, sure. I would say you have to move. However, you cannot sit around. You've got to do things. Move your arms, shake your arms, yeah, just the shaking. Yep, shaking is great. Whatever you put into your mouth affects your body. So eating as clean and healthy as possible, however you eat. Doesn't matter to me what you eat, just as long as it's healthy and clean. And then, finding something that helps your lipedema, whether it's compression or a pump or a roller or social media, talking to family, reducing your stress. Stress is so important in lipedema. And, women with lipedema have this high interpersonal sensitivity. They're very empathic. They take on the feelings of other people, and then they create stress, and stress creates inflammation, no doubt about it. So do something nice for yourself that reduces your stress.
That's adorable.
I agree totally.
Anything else?
But just to add another aspect, still today more patients have not performed to laboratories examinations. Above all, just say the vitamin D, the glucose metabolism, just study the possible insulin resistance, the possible thyroiditis or thyroidism. These are some aspects, and also if not performed gynecological controls, possible with pelvic ecography, just to define also these aspects. In patients not studied, but there are more patients not studied, above all for the regarding the laboratory aspect. This is very important.
That's great. Thank you so much, doctors. I know that our audience would love us to go on all night picking your brains, and we very much feel that what we've been talking about are things that can run and run. So thank you both for giving us something that we can all go away tomorrow and start looking at, whether it's how to get blood tests or how to start waving and shaking our arms. I look forward to loads of people with lipedema on social media shaking like trees.
Yes.
Get in and get out.
I will collaborate with the Lipedema World Alliance.
Thank you. Yes,
Definitely.
and you're right. We really encourage everybody to contact us. It's the summer now, so we will be communicating more with people about the Lipedema World Alliance from September. So anyone who's keen to get involved, please follow up with us. You can reach out to any of our organisations through our social channels, and you can email info@andlinfa.pt. Manuel is kindly coordinating interest for us, and we'll be sending more out, won't we, Valeria, as we get to September. And I think that's probably, I guess, really some of what we want to say. Is there any other closing remarks we want to make, team?
I don't think so. Just a very, very final thank you, because we could keep our doctors with us together until midnight, maybe, but we have to let them go. And a super big thank you to all the team, and thank you to our doctors who are supporting us in this way so passionately. So we feel you are super close to us, and that's exactly what the patients need. Good healthcare professionals standing and fighting side by side to us. We feel supported and we feel cared, and we feel loved, because caring is also a question of love. So thank you for your love, like this.
But if I can, Valeria, it's important also the reciprocal aspects. For us, for me personally, but for us operators, the action of patients is a very strong stimulus to
Agreed.
from the clinical examination of patients.
Thank you. Thank you.
Love
Doctor.
goes both ways.
Yes.
It does, and we're lucky to have you. So I hope what everyone can take away from this is kind of that love going all around.
Yes, let's
and
do our
as Dr. McLean said, anyone who's been inspired by us tonight, if you're running a sister association to us, please get in touch. If you're a person affected by lipedema or just interested in lipedema, please reach out to your own national associations or to one of us, because there really is always opportunities for people to get involved in supporting our work, whether that's through donations, through sponsorship of events, or through kind of giving some of your own time and skills. If you want to get involved, please do. There are so many opportunities with all of our national associations. So don't hesitate if you're wondering how to be sitting where Valeria, Marcella and I are right now, because we all started out by sending someone that email. Please do the same.
Yes.
And as our doctors have said, do your shaking. Think about what blood tests you might want and how you maybe could go about getting some of those. So I think I've been asked to repeat them. We had vitamin D, insulin resistance, glucose tests around. So not just diabetes testing, but what your functioning is on insulin resistance, and really just kind of thinking about what we're doing in terms of both moving and what we're eating. I think that was a summary of your top tips. And we can't wait to be back in September with more news, more communications about our collaboration. And in the meantime, if you're a sister association who wants to sign up to our manifesto, drop us a mail, get in touch. See you on our socials, right?
Yes.
Perfect. And have a great night, everybody. Move like trees.
Have a great night. Thank you all. Thank you. Bye-bye.
Bye.
Thank you.
See you.
Bye-bye. Thank you.
Bye, everybody.